Good afternoon, dear colleagues. Good afternoon, Professor Dazert.
Good afternoon. Hello, Professor
Hello.
Rueff, dear Peter. Hi.
We can start the next lecture on our lectures. Hearing quality is the life quality, and this is the third lecture, and this is the surgical treatment of hearing impairment. And we continue with the lecture. Please, Professor Dazert, your lecture.
Well, thank you very much, dear Peter, for the kind introduction. Dear colleagues, ladies and gentlemen, good afternoon. It's a great pleasure to welcome you to the lecture series, Hearing Quality is Life Quality. And during this year, we have discussed already how hearing works, what is the importance of hearing for human beings. And the last time in September, we talked about different origins of hearing loss and conservative treatment. And as Professor Rueff mentioned already, the topic of today is surgical treatment of hearing impairment. For those who do not know me or didn't have time to follow the last sessions, I am from Bochum, Germany. Bochum is in the midwestern part of Germany, just opposite to Berlin. This is about 400 kilometers here, the distance. And this is the city of Bochum, where I am working at the Ruhr University, one of the biggest universities in North Rhine-Westphalia. I'm the director of the Department of Otolaryngology since a couple of years, almost 20 years by now. And most important in my short CV is that I am a proud honorary member of the Bulgarian ENT Society for more than 5 years now. So today we will talk about surgical techniques in different diseases of the middle ear and the external ear. These are my disclosures that should not interfere with the contents of my lecture. This slide I showed you the last time already, giving the different types of hearing loss. We have talked already about sensory neural hearing loss during the last session. And talking about middle ear surgery, we mostly deal with patients that suffer from a conductive hearing loss or from a mixed hearing loss. Conductive hearing loss mainly, or diseases with conductive hearing loss, mainly affect the external auditory canal, the tympanic membrane, and the tympanic cavity, so the middle ear space, with malleus, incus, and stapes, and also the eustachian tube. And further central, we find the cochlea and the hearing nerve, and then the central auditory pathways. Looking a little closer to the anatomy and the pathology of this interesting area, we see that diseases of the external auditory canal may affect the skin and the subcutaneous tissue here in this area. The most simple origin of conductive hearing loss is the accumulation of earwax. So if earwax blocks the outer ear canal, patients may suffer from conductive hearing loss. And if you remove the earwax, then the patient is cured, so to say. This is the easiest disease in marks we have to deal with. Other diseases may be infectious diseases of the external auditory skin area with swelling, with secretion, and a running ear that also blocks the canal and goes along with the conductive hearing loss. We may also see benign and malignant tumors of the external auditory canal. I will show you an example of exostosis of the outer ear canal in a few minutes. When we go further towards the middle ear, we first meet the tympanic membrane that separates outer ear canal from the tympanic cavity. Reasons for conductive hearing loss in the tympanic membrane area may be perforations or defects which come from trauma or which come from infection, for instance. And these diseases may also affect the ossicles, malleus, incus, stapes here in this area. Also, the eustachian tube may affect the middle ear area. So if the eustachian tube is blocked, for instance, in little children by hyperplastic adenoids, we may find fluid behind the tympanic membrane. So if this cavity is filled with fluid, we also see a conductive hearing loss. So there are several diseases I want to go through during the next minutes together with you that may lead to conductive hearing loss. And before we start, I would like to lead your interest to other structures which are very close to the middle ear space. This is the facial nerve here. This is the semicircular canals, so the vestibular organ, and of course, the cochlea, the inner ear. And these structures are in close vicinity to the tympanic cavity. So diseases of this area may affect also these structures. And if you have a patient with vertigo or dizziness or hearing loss, we also have to check whether there is a middle ear disease, for instance. At least that needs to be excluded. Also, the internal carotid artery is very close in this area, so the middle ear surgeon needs to know where we find the arterial and venous tissues. I shortly want to guide your interest to the smallest bone of the human body, which is the stapes, with a height of about 3.5 millimeters, so very tiny. And with a height of 3.5 millimeters and an anterior and posterior cross. And this cross is designed with a hollow grinding, so it's hollow from the inside, like a pillow from a bridge. And that makes it stable and light in the same way, which is important for the stapes. It looks like a stirrup in horseback riding, where you also find the footplate and the superstructure of the stapes. The head of the stapes, this area, is connected to the incus by a joint, and in between is a little disc. So the ossicles are connected to each other by real discs, which is, in my view, amazing for such small microstructures. So smallest bone in the body is the stapes. Ear surgeons' work mainly affects the ossicular chain, malleus, incus, stapes. Here again, you see the joints in between the ossicles, and also the tympanic membrane is in the main interest area of the ear surgeon. This picture I found in Professor Ruev's office, and I liked it so much that I wanted to show it to you. So this guy is also working with the malleus, the incus, and the stapes, of course. During this lecture, I would like to speak about diseases of the outer ear canal, chronic otitis media, suppurative otitis media, and others. I would like to speak about tympanic membrane and ossicular chain reconstruction techniques. I would present to you the case of otosclerosis. And last not least, talking about middle ear surgery, we have to mention cholesteatoma. You see the exclamation mark here behind the word, and that should direct your interest to the fact that cholesteatoma is a very dangerous, potentially dangerous disease. And if you have this suspicion in a patient for cholesteatoma, action is necessary. So you need to be active. You need to send the patient to an otolaryngologist who knows how to further treat the patient. We will talk about that later. Before we start with surgery, we have to do the diagnostic steps. We talk to the patient about the medical history. We perform a complete ear, nose, and throat investigation with emphasis to microscopic or endoscopic investigation. We do hearing tests, also using the tuning forks. You may remember Weber's and Rennes tests, which are very important prior to surgery. And we also do radiology, laboratory, and anesthesia workup. What should you see when you look into the external canal and the tympanic membrane? This is a normal situation with a healthy tympanic membrane. It's without infection, without defect, transparent. You see the handle of the malleus, and what is important, you see the light reflects in the anterior inferior quadrant of the tympanic membrane. This picture looks quite similar. The only difference is there is a defect, a central defect of the tympanic membrane due, for instance, to otitis media, or if it's a kid, it may have had ventilation tubes and the defect didn't heal. So that probably needs tympanoplasty to close the tympanic defect. Finally, on the right side, tympanic membrane looks pretty good. You see the handle of the malleus, a clean tympanic membrane, the light reflects, but obvious is this area with this granulation tissue and detritus in the retraction pocket, reddish area, vessels in this area. Please keep this picture in your mind. This is how a cholesteatoma looks like. And again, the exclamation mark. I would like that this should be the information you take home after the message, that cholesteatoma needs further treatment, further care. This is the pure tone audiogram of a patient with a conductive hearing loss on the right ear. Let's first look to the left ear. Here we have this line. These are the frequencies, the low frequency, mid frequency, high frequency. And on this axis, we find the hearing loss in dB. Here is no hearing loss. This is normal hearing. And on the right ear, you see the upper line. This is the bone conduction line for the inner ear. So this is inner ear performance, which is quite good. And the difference, this is the conductive hearing loss up to 40 dB. So this is how a patient, for instance, with a cholesteatoma, with otosclerosis, or with a tympanic defect looks like. In many cases, we also perform radiological investigation prior to surgery, and then we mostly go for a computed tomography of the temporal bone. We look for the mastoid, which is nicely aerated. So this is a normal aerated mastoid. If everything is black, it's air, like outside. We look to the sigmoid sinus. We look to the ossicles. This is the level of the tympanic membrane. This is the outer ear canal. And this, of course, is the cochlea with the round window area and the basal turn. So a cochlear implant, for instance, goes through the mastoid and then through the round window into the cochlea. About this, I will speak the next time. We also look to the vestibular organ. So this is the posterior canal and the superior canal, looking pretty fine and covered with bone. Before we start surgery, we have to prepare the patient in this way. You see him on the operation table in the theater. You see the nurse's table, which is nicely equipped and always prepared in the same way. The surgeon looks through the microscope or through the endoscope, and he has to sit comfortable like this, leaning his arms up to be, without any alterations. And if you sit there for 1 or 2 hours, you need to sit comfortable. Otherwise, you will suffer more than the patient does. So that should be in your interest. So here again, the patient, the surgeon, the instrumentation nurse, this is anesthesiology place here. That's how we organize the operation area. Even if surgery takes place in full anesthesia, we give the patient a local anesthesia in the way that we infiltrate or inject the drug subperiosteally, like shown here. And this helps you to stop bleeding during surgery and also reduce the pain of the patient. And then he maybe needs a little less of anesthesia drugs. Coming to the ear, we have different approaches. For smaller cases like tympanoscopy, stapes surgery, tympanic membrane surgery, we use the end-oral approach, which is an incision between the tragus and the cartilage here of the earlobe. So this is the end-oral incision. For huger surgeries, for bigger surgeries, we use the post-auricular or the retro-auricular approach behind the earlobe. Let's start with a disease of the outer ear canal. I choose for you the exostosis. These are bony tumors, so to say, in the external auditory canal, here on the roof, in the anterior part, in the posterior part, and in the anterior part. In the textbooks, you can read this may be a result of cold reaction, cold water, so swimmer, surfer, scuba diving people should have more of these exostosis than other people. They are not, they don't need surgery in any case, but if the external ear is as narrow as here and earwax will collect behind it and going along with infections of the external ear, then surgery is necessary. In this case, you just see a little bit of the tympanic membrane because of all this exostosis in the outer ear canal. And what we do is we either remove him with a chisel, so this is a micro chisel here, which goes to the basis of the exostosis, and then we remove it, or we will just use a diamond drill and drill it away as shown in this picture here. We lift the skin of the external canal and then drill or chisel away the exostosis and then place the skin back to have almost normal ear canal. Tympanic membrane and the middle ear is usually not affected by this exostosis. Now I want to take you from the external canal to the tympanic membrane and the middle ear area. And we will see how to fix defects of the tympanic membrane, of the ossicular chain. And I will also present a number of diseases that take place in this area. Looking or going surgically to the middle ear and to the mastoid, we have to respect anatomical landmarks. And this is a drawing, a picture of my teacher, Professor Jan Helms, showing the good way through the mastoid, through a posterior tympanotomy to the tympanic cavity and reaching for the round window to place a cochlear implant. So you see, like in traffic light, green is the good way, yellow, be cautious, and red is dangerous. So avoid the red areas and try to stay in between the green areas. For instance, here is the border to the middle fossa. So if you go the wrong way here to the red color, you may injure the dura and liquor cerebrospinal fluid may run. Here you may go for danger to injure the ossicular chain, horizontal canal, or very important, the facial nerve. The facial nerve is mostly in our interest, and we have always to take care of the facial nerve. And this is an opened mastoid of a right ear. Here it goes into the outer ear canal. This is the posterior canal wall. And here we have drilled out the mastoid, sigmoid sinus, a little bluish, horizontal canal, posterior canal, superior canal. This is the incus. And here we have opened the cauda facial area. This reddish area is the cause of the facial nerve who comes from the tympanic cavity going through the mastoid. So all these landmarks are very important to know, to find, and to respect, not to do harm to the patient. Looking to a patient with a central perforation, a central defect of the tympanic membrane, for instance, by chronic suppurative otitis media, we go ahead and fresh the borders of this defect with a sickle knife. This is what is done here in the way that we get a fresh, bloody border. And then we also do it in a way that we remove skin that may be grown to the inside of the tympanic membrane. And then we harvest cartilage or perichondrium or fascia to perform an underlay. So this is the defect here, tympanic defect. And then we underlay our graft, our cartilage, in a way that it completely covers the defect from the inside. And this is also shown here in these pictures. This is a cartilage perichondrium graft. It will be slided in under the defect, and then we close it and let it heal. So underlay technique. When the ossicles are defected or damaged, we may have to reconstruct the ossicular chain, either in the way that the reconstructed tympanic membrane goes directly on the head of the stapes. We call it classic type 3. Or we place a graft in between stapes and tympanic membrane. This is a partial reconstruction of the ossicular chain, tympanoplasty type 3A, according to Wolstein. You know these classifications.
Stefan, excuse me.
Yeah.
Your screen is not presented now.
Okay. So what do I have to do?
Can you check again and share your screen?
Well, it says it's okay. I close it. Präsentation fortsetzen, Bildschirm, Präsentation fortsetzen. Can you see it again?
Yes, you can see now.
Can I continue?
Yes,
okay. Please. Okay. So this is the case of partial replacement of the ossicular chain. If the superstructure of the stapes is also missing and only the footplate is present, we do a total replacement. And this is a type 3B. For this reconstruction, we can use the patient ossicles, but nowadays we usually use alloplastic materials, and the most common material is titanium. This is shown in this example. We have little titanium prosthesis with a basket which goes on the head of the stapes and the plate which goes right under the reconstructed tympanic membrane. These are dummies where we try out the length and then we choose the correct length of the prosthesis. And here you see the little basket on the head of the stapes. This is the reconstructed tympanic membrane with cartilage, and the plate of the prosthesis goes right under the cartilage. So if that heals, we have an almost normal situation of the tympanic membrane. I mentioned already that we will talk about cholesteatoma. This is another picture of cholesteatoma with an almost normal tympanic membrane. You even see the light reflex here. But in the epitympanic area, you see this granulation situation. There is a retraction pocket where this infection is inside. And starting from this area, the cholesteatoma may eat up the middle ear structures, may destroy the middle ear structures like caries in teeth, for instance. So it's a chronic bone infection. Abnormal skin growth will be found in the middle ear. So if squamous epithelium comes together with middle ear mucosa, a cholesteatoma will occur. And it's dangerous because of its destructive and expanding growth behavior. It may destroy the ossicles, the facial nerve, the vestibular system. It may go towards the skull base and may also reach the meningen, so may end up in meningitis and even in an intracranial abscess, which is a life-threatening disease. And therefore, it's so important to recognize this disease in your patients and send the patient to someone who knows how to surgically treat this. Surgically therapy is the only therapy that is available, so there is no medication, no drug that will help against cholesteatoma. And that's why I'm so pushing on this disease. And I would be happy if you keep this in mind from this lecture for your whole life, that cholesteatoma is a dangerous thing. This is an example of a child with a so-called primary cholesteatoma. It looks a little different to the pictures I showed you already. You see this white mass behind an intact tympanic membrane. This is the tympanic membrane. And when we open up the tympanic membrane and look into the middle ear, we see this whitish ball. This is chorda tympani, which is ballooned a little. And the technique of cholesteatoma surgery is the inside-out technique. So what we do, we remove the posterior canal wall. This is bone, the bony wall of the external canal. We remove it as far that we can remove completely the cholesteatoma out of the middle ear and the mastoid spaces. So the posterior wall separates the external canal from the mastoid. And you see all these whitish cholesteatoma masses. They need to be completely removed, otherwise you will have a recurrence of this disease. So here we have a relatively huge defect after the removal. This is the head of the stapes. This is facial nerve here, down there. Sometimes it's not covered with bone anymore. This is the promontory and the round window niche. And this is chorda tympani. And now we need to reconstruct the ear to give the patient a good function and a good hearing. And to reconstruct the defect of the posterior wall, we like to use cartilage from the earlobe. To reconstruct the ossicular chain, we take a little prosthesis, you see here, which is covered with cartilage. And then the tympanic membrane can be replaced like this. So this is the picture at the end of the surgery. This was the picture at the beginning of the surgery. And you see, there's not much difference. The only difference is that the cholesteatoma is removed. And this patient, of course, needs care for many years, probably for his whole life, because of the dangerous disease. I also want to speak with you about otosclerosis, which is a disease with an unclear etiology, starting with conductive hearing loss, sometimes going along with inner ear hearing loss. And the origin is obviously bone remodeling processes at the area of the stapes footplate, which lead to a stapes ankylosis. So a stapes fixation is the reason for the conductive hearing loss in otosclerosis. And these are histological pictures. And what you see is this is the stapes footplate. This is the external auditory canal. This is the vestibular organ. And when you look here from the stapes footplate towards the adjacent bone, you see the otosclerotic fields that fix the stapes here in this area. And sometimes these otosclerotic areas go till to the cochlea. This is Reisner's membrane. This is organ of Corti down here, scala vestibuli, scala tympani, scala media. And in this cases, the patients also suffer from a sensory hearing loss, so they have a mixed hearing problem. So main leading symptom is conductive hearing loss. In some cases, they also have a sensory hearing loss. Half of the patients suffer from tinnitus. Some of them have vertigo. And usually we find a wide and open external auditory canal and a well pneumatized mastoid. So what can we do in these patients? We can suggest a hearing aid, for instance, which is one option. But most patients, because these are usually younger patients, they don't want hearing aids. They ask for alternative treatment. And in these patients, we can suggest the so-called stapes surgery or stapidotomy. This is a small surgery taking about 30 to 45 minutes with low risk and a high success rate. So when you talk to your patients about the success rate, you may tell them that in more than 95%, people have a better hearing after the surgery than prior to surgery. And the risk is low, so this surgery can be recommended to the patients. And what are we doing during surgery? I show you on these pictures. Here the tympanic membrane is opened. This again is the chorda tympani. And you look into a right ear. This is the long process of the incus. This is the stapes. This is the stapedial tendon. And we open the joint between incus and stapes. Then we cut the tendon, stapedial tendon. And we have tested before that malleus and incus is mobile and the stapes is fixed. This is the view to the footplate, stapes footplate, and there is no moving visible in the stapes area. The next step is to remove the stapes superstructure. This is done with a little 0.4 millimeter hook. So the superstructure will be removed. And then we have a clear view to the fixed footplate. And then we go to the posterior part, to the posterior third of the footplate, because there is the longest distance between footplate and the organelles of the vestibular organ. So this is utricle and this is saccule. And here we have more distance than in the anterior part. That's why we go with our perforator to the posterior third of the footplate, create an opening, a stapidotomy like this. So now we are looking to the perilymph. So this is an artificial perilymphatic fistula, so to say. And then we use a nice small prosthesis This is a titanium prosthesis with a length of 4.5 millimeters. So the distance here is 4.5 millimeters. And the thickness is, for instance, 0.5, the diameter of the stamp here. And we exactly place the prosthesis in the stapedidotomy, in this opening here. And then we guide the loop over the long process of the incus, as shown here, and then close it with a little crimper. This is the micro crimper to close the loop around the incus. And now we have a mobile system again. When you move the incus, the prosthesis moves, and the sound information from the tympanic membrane will go over the ossicles, over the prosthesis to the inner ear. And after 4 weeks, the patient can almost do anything, can start sports again and his normal life. 4 weeks after surgery, he should be a little calm and do no sports to give a chance for healing for all these areas. So we have looked to a number of different middle ear diseases which affect hearing. And today, conductive hearing loss or mixed hearing loss was our main topic. And middle ear surgery aims for several things. First of all, the disease needs to be removed. So the chronic infection of the ear, the cholesteatoma, for instance, sometimes you have benign or very rarely also malignant tumors. Removal of the disease is the first aim, but right after that, we are looking for the best possible hearing. And this is the main topic of this lecture series, hearing and hearing reconstruction. So when we were successful to create a dry ear, a ear with no pain for the patient, ready for all activities in leisure time, in profession, in sports, whatever you want to do, the patient also needs to get a very good hearing and a good ability of communication, which is the basis of social integrity in everyday life. And here we meet all the things we have learned in the last 2 sessions, that hearing is very important and hearing is necessary to gain a good life quality. And my next visit to Trachea University will be in March next year. Then we will meet in person, and I'm really looking forward to that. And I'm more than happy to present you my last presentation, which will deal with indication and surgery of implantable hearing devices, such as cochlear implants. I have just mentioned it shortly. And there are even more implantable hearing devices like bone conduction implants or active middle implants. This is a very interesting topic, and we will speak about this in March next year. So I will finish my presentation today with the main expression of all these lectures. Hearing quality is life quality. Please keep this in mind. And when you look at your patients, independent whether you are an ENT doctor or a general practitioner or children's doctor, this is very important to remember. And I hope you learned a little bit more about the topic of hearing today. Thank you very much for your attention. And if you have questions, I'm more than happy to answer. Thank you so much.
Thank you, Professor Dazert, to did a very interesting lecture with a good overview of the middle ear disease and their treatment. Do you have questions, colleagues, and comments? I have one question about the quality of life. which tools you use to check the quality of life after ear surgery? Do you have
Well,
experience?
there are several questionnaires available for that. And there are also disease specific questionnaires available. And if you give your patient these questionnaires, they are available in English, of course. We have translated them into German language. And maybe we have to look up whether this is also available in Bulgarian language. You can follow up your patients and you can give them the questionnaire prior to surgery. And let's say 6 weeks and 3 months and 6 months after surgery to see what kind of benefit they have from your surgical procedure.
Another question? From the people online, have have question from colleagues online? Please, when you have, put the button of the microphone and say your question, or you can write in a chat.
Maybe we can check the chat. You can check it probably, right? The chat.
Yes, I check.
Okay. Yeah. So most
Nobody.
important, I would be happy if you remember cholesteatoma. So whenever you see a patient with cholesteatoma, with a running ear, with very bad smell, then send the patient to an ENT specialist who can take care of him and prevent from dangerous complications.
I have another question.
Sure.
Do you make for every patient with cholesteatoma CT scan or not?
In patients with cholesteatoma, we do almost in every patient a CT scan. I think it's mandatory if the patient has problems like vertigo, pain, severe hearing, inner ear hearing problems. In these cases, it's mandatory. But during the last years, we are doing CT scans for almost every patient with a cholesteatoma to see the extension and to see what specific structures in the middle ear and maybe also skull base and inner ear are affected by the disease.
We know that this disease have recurrence.
Mm-hmm.
How you check the recurrence after this surgery?
In some patients with a very extensive cholesteatoma, we indicate a so-called second look surgery. That means after about 1.5 years, we ask the patient to come back for another, hopefully short surgical procedure. We open the ear and we check the middle ear and the mastoid area with the microscope and with the endoscope whether there is a recurrency. If not, it's fine. If we find a recurrence, we remove it and also try to improve hearing during this session. For a couple of years, a new method is available, a specific MRI tool, which is called, I have to think about English.
Diffusion whitening imaging.
Thank you very much. Okay, I just have it in German in my mind. And this specific MRI allows to give you some evidence whether there is cholesteatoma or not. For a positive MRI, the cholesteatoma needs to be bigger than 2 millimeter. Smaller cholesteatomata you would not find in the MRI. So we have to wait for the future whether the picture, the MRI, is valid enough to not go for second look surgery. But at present, we still keep with second look surgery when it's indicated. Not in every patient, but in those patients with extensive disease.
Thank you for this explanation. More questions? when we don't have in the chat. No, we don't have. Thank you very much, Stefan, for this very interesting lecture. And I hope we see you again in March personally in our university.
Thank you very much for listening and for organizing all this. It was a great pleasure to me to give this lecture, and I'm looking forward to see you, hopefully all, in March in person in Trakia University. And I wish you and your families a nice Christmas time and a happy New Year.
Stefan, we have a question from the chat.
Okay.
The question is, once you diagnose the primary cholesteatoma, when do you perform the surgery? At what age?
Well, it's not an emergency indication, but I would suggest to do it pretty close to the diagnostic time, because if you wait, the cholesteatoma may grow and get as big as I showed you on these pictures. So usually I tell the parents, let's go for surgery in between the next 3 months. And you can also do it in a 2-year-old child. This is not a problem, because the ear is pretty much grown up even in small children. So surgery can be done even in young children with a disease like this. So I would go for surgery pretty soon.
Thank you. Thank you, Stefan, and thank you for your kind words. And I wish you all of us good time and see you again.
Yeah, thank you very much. I see Nikolai Kirov on the picture. Hi, Nikolai. Nice to see you.
Nice to see you, Professor Dazert.
And Peter, thank you very much for organizing all this, and have a nice afternoon.
Bye-bye.
Thank you very much. Have a nice day. Bye.
Ciao.